My name is Carrie Page, and I chose to do my presentation on 5-alpha reductase deficiency. The patient presents as a 13-year-old female who is referred to pediatric endocrinology by adolescent medicine for abnormal routine physical. The referral reason is amenorrhea. During the intake process, upon review of systems checklist, it was noted that the patient complained of no breast development, no menstruation, and a small amount of facial hair. That's very fine. The parents were concerned for PCOS or delayed puberty. During the physical exam, the patient was noted to have no breast development, ambiguous genitalia, splenomegaly, and very small, fine amount of pubic hair. She ordered a series of tests. She ordered a bone age to check to see if the skeletal age compared to the chronological age. She also ordered a pelvic ultrasound, a full hormonal panel, a karyotype, and upon review of the bone age showed that the bone age was consistent with a 13-year-old. However, it was consistent with a male and not a female. The pelvic ultrasound results showed that the patient had no uterus or ovaries. So she ordered a vaginogram, karyotype, and HCG stim test. The hormonal panel showed an elevated DHT of 3.5, estradiol of 31.4, which is consistent with the early follicular phase, and the progesterone was 4.5, which is consistent with the luteal phase. The vaginogram resulted and showed a 4-centimeter blind vaginal pouch. She also ordered an HCG stim test after that, which revealed the testosterone to dihydrotestosterone was further increased to 29.4, which confirms a diagnosis of 5-alpha reductase deficiency. So for normal development, the 5-A reductase is an enzyme that converts testosterone to 5-A dihydrotestosterone in the peripheral tissues. DHT is a potent androgen that is necessary for the development of the male external genitalia in utero. The gene processes androgens and it converts testosterone to DHT, which stimulates the androgen receptor to make all things masculine in the DNA. So the abnormal pathophysiology this would be caused from mutations to the SRD5A gene. It would prevent DHT production, which would cause ambiguous genitalia. They may look like they're a female. They'd have absence of breast development. They wouldn't menstruate. They may have a phallus. It may be small. And then with puberty, once puberty hits, all of that will develop. I've included a photo of how the normal adult male and a normal adult female would look. And then with that 5-A reductase deficient male, how their genitals may look without that enzyme. So the anticipated pubertal development, the amount of testosterone produced during puberty is enough to cause virilization, which would develop the penis and increase the testicles in size. Patients would have increase in facial hair, their shoulders would broaden, they could develop an Adam's apple, their hips would thin, their voice would deepen and crackles start to deepen as they hit puberty. So they will begin to change into a male and start looking like a male. For family and patient considerations, there's obviously a lot to think about, just because, if this patient has been raised as a girl and they physically have looked like a girl all of their lives, even if they've looked like a girl, maybe they've, told their parents or always felt with their parents that they've always wanted to be a boy and they felt like they were a boy and it wasn't really accepted. It was kind of pushed away. It's going to be hard on a family to come to terms that their child that they always thought was a girl, named as a girl, raised as a girl, is not a girl. Legal implications, even though the karyotype is XY, and if the child decides that they want to be a girl, a lot of states will not allow gender reassignment or removal of the gonads until that child is over the age of 18. And a lot of families and kids don't think about the effects of fertility at that young of an age, so they may wait till they're older to decide, if they want to be a girl. They're obviously not going to be able to carry a child because there's no ovaries or no uterus. And if they want to be a boy, they may need the help of IVF. The micropenis may not allow them to have intercourse sufficient enough to create a child. So a lot of families may let their children choose a gender, but like I said, with the legal implications, they may not be able to choose that gender until they're 18. And depending on what they choose, they may need reassignment surgery because the development may not be fully as a male. So with this, the medications that would be needed is IM testosterone. This would be given to kind of help along and give a boost to further develop the testicles and the penis. Or if they feel like the child is not developed enough psychologically, they could give a GnRH agonist such as Lupron or Supprelin to kind of suppress that puberty until the child is old enough to decide for themselves what gender they want to be. As far as consults, you would want to consult plastics in case, if the penis, the phallus, the testicles aren't developed enough to where they need reconstruction or lengthening of the penis, or if they decide they want to be a female, they can remove the gonads. Also, family counseling, like I said, this is a very trying time. Their child that they may have raised one way and believe their child is a girl for 13 years is no longer genetically a female. Urology, just to rule out any issues with male reproductive organs, and then genetics, just to kind of follow up with them, if their karyotype is an XY, to see if there's any chromosomal abnormalities or if it'll run in the family, future children, and what their risk is in that. Nursing considerations, obviously as a nurse, you want to be sensitive to this. This is it's a very trying time for families to realize that a child that they thought was a girl for so long is not a girl. You want to be reassuring. A lot of kids feel like they're not normal when they find out something like this, or families are unsure of how to raise their children, how to continue on, which direction to take, and just encouraging counseling and psychiatric help. Just to kind of get them through and help them decide on something that they can all agree on, and a path that they all want to agree on. And then as a nurse, you can educate on how to give the IM testosterone and just the different ways, the Lupron, the Supprelin for suppressing puberty, how those work, how they're placed, and just side effects of those medications. So I've included my sources, and I hope you enjoyed my short, quick presentation about 5-alpha reductase deficiency.